Good evening, everybody. Dear colleagues, professors, and guest speakers, it's my pleasure to join you through this, the second session of our webinar today, titled Hypoxemic Respiratory Failure in COVID-19, Where Do We Stand? I'm Dr. Mohammed Al-Gindi, Assistant Professor of Anesthesia, Critical Care, and Pain Management at Shams University. I would like to welcome first my co-moderator, Professor Dr. Ahmed Fouad Madi. He is a professor in Toronto University and senior consultant of anesthesia and critical care medicine in King Saud Medical City. Also, it's my honor to introduce our guest speakers in this roundtable discussion. First, Professor Dr. Laurent Bouchard. Hello, Dr. Laurent. Dr. Laurent is the director of the Interdepartmental Division of the Critical Care Medicine, University of Toronto, Canada. Actually, he is a Kenan Chair in Critical Care and Respiratory Medicine. Sure, he is a Senior Clinician Scientist, Critical Care Department, St. Michael Hospital. Thank you for accepting our invitation.
Hello, and thank you for the invitation. Thank you very much. And it's very interesting to see that the same questions are all around the world. So,
thank you.
Thank you so much. Thank you so much, my dear friend, Dr. Mohammed. Thank you. Actually, I'd like to present my professor. Actually, I honor to be with us here, Dr. Yassin Arabi. Dr. Yassin Arabi, welcome. He's the chairman of Intensive Care Department and the medical director of Respiratory Service. He's professor in the College of Medicine, King Saud Ibn Abdulaziz University for Health Sciences in Riyadh, Saudi Arabia. And as well, he's section editor in the Intensive Care Medicine Journal. He's adjunct professor in Monash University Hospital in Australia. Dr. Yassin Arabi is well known actually worldwide, and he's a member of many international committees worldwide, and he's actually one from the task force to having the guideline of survival sepsis campaign, as well as a Canadian guideline, which is just published 2 days back. Thank you so much for that. Dr. Yassin, of course, he is a principal investigator for many landmarks, actually multi-center study, like Miracle, like Prevent, like MERS-CoV. I can conclude he has 250 multiple publications worldwide, as well as until yesterday, he has 19,000 citations from Google Scholar. Thank you, Dr. Yassin, and welcome with us.
Thank you, Prof. Ahmed and Prof. Mohammed for the invitation. It's my honor to be with you tonight.
Thank you. Actually, it is, as you know, it is a roundtable discussion with experts in acute hypoxemic respiratory failure of COVID-19. I'd like to start actually with our Prof. Dr. Yassin. Dr. Yassin, the COVID-19, actually, if we classify it by the standard classification, is it a syndrome or it is just a viral infection?
Thank you very much for this question. So this is the third coronavirus in the last 2 decades that caused a major pandemic to various degrees, obviously. So we had the SARS, we have MERS, and now we have COVID. And all of them are considered syndromes by the name of them because they involve multi-organ involvement. Interestingly, these three syndromes have similarities, although they have some differences, but there are similarities that worthwhile mentioning. These three coronaviruses probably started from animals, so they are zoonotic in one way or the other. The SARS start from bats and maybe from civet cats, and the MERS from camels, and this one we believe it's from bats. This by all means, this is a syndrome because it has multi-organ involvement and manifest in different organ dysfunction.
Thank you, Dr. Yassin. Actually, my second question about the pathophysiology of the COVID. Dr. Yassin, almost you are the most expert one in MERS-CoV, and most of the application related to you because actually it was more popular in Saudi Arabia during that time. Do you have any difference between the pathophysiological with the MERS-CoV and COVID-19? or just because extensive study with the peripheral surgery of the COVID-19 we discover many things which was not present in the MERS-CoV?
If I can share a couple of slides, perhaps.
Sure.
Yeah. So what we, I think the current thinking of COVID-19 is that there are multiple pathophysiologic mechanisms involved. Of course, you have the infection by itself, the virus causing injury to the organs and leads to lung injury and perhaps to other organ injuries. But also the infection induces massive increase in pro-inflammatory cytokines. It's called the cytokine storm. And that's also induce lung injury and other organ injury. And there is this observed phenomena of increasing thrombogenicity in the lung and other organs as well. And that also contribute to the lung damage. Now, is that different from MERS or it's similar? Well, that's a very good question. I think COVID-19 has undergone much more extensive studies than MERS. So perhaps we are discovering things that were not discovered. But having said that, I think probably there are a lot of similarities. We observed thrombosis also in MERS. The cytokine storm, we have a paper now under review for cytokines, and I think probably not much different from COVID, and not much, perhaps even from ARDS, when there are multiple cohorts where they looked at the cytokine patterns using latent class analysis, and they found that patients have different patterns of inflammatory markers. Some are hyper-inflammatory and some hypo-inflammatory. So actually in our paper in MERS, we have found 40% of patients would be hyper-inflammatory and the others are hypo-inflammatory. And you could argue that these patients would differ, perhaps behave differently to different therapeutics. Also, there have been several autopsy studies on COVID-19, which showed that there is in situ thrombosis in the lung, and other organs, in addition to the diffuse alveolar damage and the parenchymal injury. This is a study from just published from France, where they looked at, this is a radiology study, looked at spiral CT scans performed on hospitalized patients with MERS, and they found in this series 23% have acute pulmonary embolism. Of course, there is no good control here, but suggesting maybe there is increased risk of venous thromboembolism. And this paper just published in New England also suggesting that there is increased risk of stroke, large vessel stroke in patients younger than 50. All these together suggest that there is increased coagulability in these patients, and it triggers the interest of considering anticoagulation or high-dose prophylactic anticoagulants.
Thank you, Chris. Ahmed?
Okay, this is a very nice illustration, actually. I have a couple of questions for our distinguished guest speakers about what do you think in this insightness? Do you think that this pathology is actually not a primary pulmonary pathology? It's a systemic pathology, truly, and does it start by the lung or an upper respiratory tract, then lower respiratory tract, or it is a disseminated systemic pathology affecting the whole body by the theory of microthrombi and the cytokine storm? And if so, So the cytokine storm, does it start early in the pathology, or it is a second stage after viral invasion? Please, Dr. Laurent.
Well, thank you. That's a complicated question. I just want to come back to the preceding question just to say that there is one difference between the actual pandemic we see and the preceding ones is the highest number of interconnection between people. I'm saying that because we have seen so many reports already that it's becoming to be confusing, and people saying, well, is it, as the question you ask, which were very right, is it a syndrome, is it an infection? And Dr. Arabi mentioned that not all patients are the same. So I think we have to be careful, and it's clear that it's a systemic infection, but with a lot of lung presentation and lung symptoms. Regarding the cytokine storm, as already discussed, we also have seen a lot of reports where cytokines were elevated, but only very mildly. So you cannot say, for instance, all patients will have this pathophysiology and will do the same. So I would say, because we hear so many things about this disease, and we are all a bit nervous, right? A bit even scary. We tend to forget that, for instance, the patient we see in the ICU, they will have ARDS. Even if these ARDS have some specificities, I think, they will have ARDS. And the first description of ARDS, the series, the autopsy series by Warren Zeppel and other, showed that ARDS was characterized by microthrombosis in the lung. And we also know that many patients in the ICU are at risk of DVT and pulmonary embolism. So yes, they have specificity, but we should not see this disease as completely new, right? We need to build on what we knew already. For instance, we know how to treat ARDS in general. We have specific rules. We know how careful we must be with these sick patients in the ICU in terms of DVT prophylaxis and things. And just be aware that there are some specific aspects which may need to be considered more. But for your question about a systemic disease, yes, it is a systemic disease, but the manifestation very likely depends where are the receptors for the virus in the body. And a lot of receptors are in the deep lung. That's why we see a lot of lung presentation.
Okay, thank you.
Thank you, Dr. Bouchard. Actually, I think we have a lot of challenges, actually, not only for epidemiology or definitions, even for diagnosis and management. If we go to the diagnostic challenges, actually, Prof. Yassin, we have many diagnostic and severity markers related to the COVID-19. If there is, in your opinion, there are some golden markers we can rely on for the severity and diagnosis of the COVID?
Good question. There are many markers described in the literature. Now, what's a clinical utility for the of this in the bedside? That's to be determined. I pulled one systematic review of biomarkers, and there is a long battery of biomarkers people used. Many of them are regular tests we do at the bedside, but also the D-dimer to look at coagulation, serum ferritin as a biomarker, and there are people who are doing IL-6 to guide the use of immunomodulator. But I think these are at present good to be used in research protocol, because we are not certain how would they guide therapy. The idea from these inflammatory markers that these may predict hyperinflammatory status, and as Dr. Bouchard mentioned, we think not all patients have hyperinflammatory state or cytokine storm. In fact, this is what we've seen in MERS, only 40%. So if you blast everybody with immunomodulators, you may help some, but you may harm others, and that's a problem. So these are some of the biomarkers described in the literature, but as a clinician at bedside, we're not really certain how this can help us at this point. D-dimer, maybe, D-dimer for coagulation. Yeah, perhaps that's a reasonable one to do.
So based on that, we can find some scores which would be valid to be assessing the severity of such a disease if we are collecting these golden biomarkers.
Yeah, I meant to mention. So some people proposed the H-score, for example, so a collection of different biomarkers. Sorry, good question. And that include multiple of these biomarkers. But again, how is it validated? Is it validated in COVID? The answer is not yet. So if I do the score, would that dictate certain treatment? We're still not certain about this. There are clinical trials ongoing now about using different immunomodulators, anti-IL-1, anti-IL-6. So I think we need to wait to see how this come out.
Thank you. Mohammed?
Okay. I have a lot of questions in the chat room, actually, for our distinguishable guest speakers. My question to Professor Laurent is about what do you think, why the pulmonary manifestations, radiological pulmonary manifestations, are always in the early phase are peripheral, and why the ground glass appearance is patchy or crazy paving character? What do you think, why it's peripheral and why it's ground glass appearance and why it's small patches? It's very, very unlikely to see it in other types of pneumonia.
Yeah, it's interesting because some clinicians early on started to say, well, we do CT scan in these patients early on, and we see patterns that now we recognize to be associated with the disease. It's always difficult to know whether, no one of these radiological sign on X-ray or even on CT is specific of anything. And for instance, when you do CT scan in a patient with, let's say, classical ARDS, the amount of ground glass opacity depends on the PEEP level. So, for instance, you may have just density at very low PEEP, and you see more ground glass opacity when you probably try to reopen. So I see that as a marker of an early stage of the disease, and I think it's probably related to the fact that there are patients presenting with severe hypoxemia, but without clear respiratory distress. A little bit short of breath for sure, but not high work of breathing or going to crash quickly. And that's a little bit unusual. And I think this is what pushed people to do the CT scan early, because they did not understand very well. And this is also probably why we have more information about the incidence of pulmonary embolism, because they do CT PE. So I think it may be simply that we have information at an earlier stage, because these patients develop hypoxemia relatively early. And as you know, there is discussion about when to decide to intubate a patient based on hypoxemia, and the question is that some patients look okay clinically, but deteriorate very rapidly. And also the fear that some patients who are already breathing relatively deeply, but it may be clinically hard to see, may deteriorate because they may develop what we call patient self-inflicted lung injury. So, so this question of the early stage and the hypoxemia associated with the images you describe are interesting because it seems to be a kind of specificity that hypoxemia arrives quite soon.
But you don't find any explanation why it's early patchy peripheral. It's not a viral invasion pattern or a pulmonary microthrombi pattern. Does it seem logical?
Again, what we are used to is to look at CT of patients in the ICU who have been already intubated, receiving fluid, being lying on the bed. So I think most of what we see usually in ARDS is related to ER management. So I think it's a localization of the initial infection. And you know, that's the difference between having an infection localized in the lung and going into the next stage, which is diffuse inflammation through, for instance, a cytokine storm and then developing ARDS. So I think we see that as at an early stage, something which exists in other kind of infection, but which we do not see all the time.
To make this more clear from our side, do we have any suggestion to put the patient on a PET-CT or PET-MRI to get more explanation? Is it inflammatory, the metabolic behavior of this problem, or what?
I think this would be very nice, very interesting, because what you may see is that you may distinguish this localized infection from the decompartmentalization, which means that there's already inflammation everywhere. But this is a research project, and it's also limited by the risk of spreading infection, and so which is makes things very difficult. But that's a very interesting question. I think what we are lacking now a lot in this infection is an animal model where we could study that, right? Because the observations we have from patients are sometimes very difficult to reconcile, to have a very clear story which is repeated from patient to patient.
Okay, thank you. We can move to the treatment challenges, Dr. Ahmed.
Dr. Bouchard, actually, yes, Dr. Bouchard took us actually to a very important point, which is the patient self-induced lung injury. It is very actually essential in the patient's awake patient's hypoxemia. And I can actually refer the question for Dr. Yassine. Dr. Yassine, those patients usually coming with hypoxemia, maybe with or without increasing work of breathing, and management early before intubation is challenging between, we are weighing the risk between the effectiveness of the oxygen therapy as well as the spreading of the infection. So my question, what is the optimal oxygen therapy for such patients, and exactly when we can proceed for intubation for such case and to prevent patient self-induced lung injury?
Yeah, so there are several guidelines that now been published. There's the WHO guidelines, there's the Canadian guidelines that came a couple of days ago on surviving sepsis campaign guidelines that might be useful to look at. And this is a summary of the surviving sepsis campaign guidelines for patients with COVID-19 and ARDS. There are certain things that are recommended, and as Prof. Bouchard mentioned, it's mostly really general ICU care of ARDS patients. So lung protective strategy, investigate foreign bacterial infection, keep oxygen level within whatever is acceptable now is 92 to 96. Conservative fluid strategy, empiric antibiotic. In moderate ARDS, perhaps higher PEEP than lower PEEP. Neuromuscular blockers used as boluses rather than using prolonged infusion. Do not use a staircase recruitment maneuver. If you want to use traditional recruitment maneuver. Prone positioning. steroids, we could debate this. And the antivirals, I think there's a separate session for it, so I'm going to leave it. So what do you do if a patient with hypoxia? Well, clearly, if he's severely hypoxic and severe respiratory distress, has a clear indication for intubation, that's what you should be doing. Intubation, get an expert person to do the intubation, and with proper PPE, minimize the staff and probably use video laryngoscope first to reduce the number of attempts and also to distance from the face of the patient. But if the patient tolerating oxygen, maybe consider high flow nasal cannula, possibly non-invasive ventilation or CPAP. I'll mention this in a second. But very important, if you use high flow nasal cannula and or CPAP or BiPAP, to monitor patient closely and not to let them, we've seen this in MERS. Patients are kept on CPAP for a long time, and they go in distress for a long time, and then get exhausted. And then when people decide this will not be a good approach. So if signs of failure appear, then the patient should be intubated. So this is the same here. I found this very interesting experiment. This is actually from a Vapotherm website about the dispersion of droplet with high flow nasal cannula. And what you could see here, high flow nasal cannula, how much the droplet are spread around the patient. On the left side, if the patient has a high flow nasal cannula and has a surgical mass on his face. Here, regular nasal cannula, low flow nasal cannula, you still have significant dispersion of aerosol, and if you put a mask, it will be much less. If the patient just breathing spontaneously, also there is also in respiratory distress, you'll have aerosol generation that will be much less in with the mask. Perhaps non-invasive ventilation has the most aerosol dispersion among all modalities, followed by nebulizer. These are not head-to-head comparisons, but just kind of summary. And high flow nasal cannula perhaps less than the others. And also, I think a practical point about non-invasive ventilation, and you need to remember that there are two types of non-invasive ventilation. One has one line, just inspiratory line. The circuit from the machine to the patient has only inspiratory line, and the expiration is a through valve. This is associated with significant aerosol generation. The other that has two circuits, inspiratory and expiratory, this probably less. And our colleagues in Italy have used a lot of helmet CPAP, and probably this will be associated with much less aerosol generation and perhaps more success. I mean, at least the descriptions we are hearing is better. You know, the trial from Chicago, the single center study showed the benefit with helmet CPAP compared to conventional oxygen. So it's, at least I would say this is a promising one. We are getting this in Saudi Arabia soon. So I'm very excited about it. I think it's going to be a nice thing. So so that's what how they approach patient with respiratory failure. Also, another aspect that is emerging is using prone positioning in awake patients. So patient with start to have respiratory distress, having them prone. I mean, this still at present case series and case reports. There is a plan for a randomized control trial to be done on this. But if prone work in the severe ARDS, it probably works in less severe ARDS. So it might be good to avoid intubation as well.
Thank you, Mohammed.
Actually, we're getting much more questions on the chat room, so I need to get through them as much as possible. Professor Bouchard, what do you think about the work of breathing in this non-invasively ventilated
About
patient?
what, sorry?
Sorry, I'm asking about the work of breathing. Is there any evidence that the work of breathing in getting the patient on mechanical ventilation or on intubated, ventilated, or it's just figures and numbers which we are depending on still?
Sorry, I'm not sure to get your question. It's about the work of breathing of the patient, but what's the question?
Yes. If I have a patient, we have a patient who is admitted by mild to moderate hypoxemia, SpO2 92 to 93%, and he's at CAT scan or CT chest is having a classical pattern of COVID, and he's a COVID-19, and he's line hypoxemic. Do you think that the work of breathing with the patient self-inflicted lung injury pathology or problem will make you to take the decision of early intubation of ventilation versus late ventilation?
Okay, this is a very good question and very, very clinically relevant and important. And the answer is not that easy. So why it's not that easy? Because what we know is that the risk of ventilator-induced lung injury is mostly due to the amount of effort done by the patient and the tidal volume taken by the patient. Unfortunately, we don't measure these two things, right? We can measure it when you do non-invasive ventilation. That's why now when you do non-invasive ventilation in an hypoxemic patient, if you see the tidal volume is higher than 9 ml per kilogram on average, the risk of failure and poor outcome is very high, so these patients should be intubated early. But if your patient has if you have no way to measure the tidal volume, it's very, very difficult to guess, and we are not good at doing that. So the way to look at work of breathing is very, very clinical. It's mostly the use of the sternocleidomastoid muscles and other accessory muscles. And even the respiratory rate is not a very good indicator, because we know that the drive it's mostly the effort per breath, and the change in rate are not very good predictors of the work of breathing. So that's a fundamentally important question, and we don't have a very good response. I would say it's a clinical decision, and as soon as you think that your patient is doing high level of work of breathing based on clinical examination, I would say yes, that's a good indication for intubation. At the opposite, if the patient is hypoxemic but tolerating it very well, and for instance, able to speak to you like I am speaking now without interruption, you may say, okay, this patient has probably not too much work of breathing. But as you know, for instance, the experience we have in non-invasive ventilation in hypoxemic patient is not very good. And the last thing we want to see is a patient intubated at 3 a.m., in catastrophe because the desaturation went down. So I would tend to say, if your clinical judgment say, yes, this patient looks to work hard, is not able to speak, more than a few words and then need to take the breath, then it's probably a good indication for intubation. So in our center, what we do is we use high flow. We try to use high flow in protected environment, if possible, negative pressure room, or at least a closed environment. I think the graph shown by Dr. Arabi was very nice, because you see the dispersion, but it's a dispersion of the exhaled air. What is really, really dangerous is when the patient is coughing, because this is these droplets which are really having a high viral load. So we do the high flow usually with a mask on the patient face, and the patient who would be coughing a lot, maybe we could decide early to go to intubation also, because of for the protection of the personnel.
Perfect. Can I get a question about why find any benefit from proning this patient in the non-invasive or pre-intubation phase? If the patient is having a good compliance, going to the very big issue of having different phenotypes and something about this. If we are going to have to admit that there is a phenotype of having compliance, so what makes sense to put the patient on proning type of cases, and what makes sense that if I prone the patient while he is not intubated, I get very good. I think any problem with the sound?
It's a bit noisy. I think you were discussing of the phenotype. That's what I was trying to describe, you know, these patients who are hypoxemic but not. I think as soon as your compliance go down, breathing is more difficult. And that's what you are looking for, right? The patient is in clinical respiratory distress. It looks like having a high work of breathing. This is not explained only by oxygenation. There must be a difficulty to breathe due to poor mechanics, which is due to low compliance. So that these patients would go to. So we don't use non-invasive ventilation because it's usually not very successful. We have been using a little bit the prone ventilation.
Yes, that's my question.
But as you know, in the ICU, we mostly see patients who are already sick, and we go quickly to intubation usually. And in the intubated patients, we have used prone position in a lot of patients. So I think we need data, we need studies on that. We have some data suggesting that it may improve oxygenation, but oxygenation is not the end of it, as we said, so it may help. So it's a very interesting approach, but we need more data.
I just pick from this the simple question: do you find the proning in the early phase with a good compliance of the lung effective? That is what you mean by your response.
Yeah. So the people need to remember that the number one reason to prone patient is to protect the lung, right? So if your patient has high compliance, the patient will not need a high PEEP. If you don't use a high PEEP and a relatively low plateau pressure, yes, proning may help, but I think it should be mostly important in the sickest patients who need to be protected against ventilator-induced lung injury. But the correlation between the lung protection and oxygenation is not perfect. So you may still protect the lung even if you see no effect or very little effect on oxygenation. So I think it's very important to prone this patient as soon as they look severe in terms of oxygenation and or in terms of pressure.
Okay. Thank you, Dr. Bouchard. Actually, the time is passing and you have many questions on the chat room. I have just a small question for Dr. Yassin. If you never mind, Dr. Yassin, those patients, if intubated, shall we go with the standard for PEEP adjustment with the ARDS net table, either high PEEP or low PEEP, the standard care for the ARDS net protocol for the PEEP adjustment for such case, or we have special consideration for them?
Yeah, thank you. So I just want to have a follow-up on the non-invasive ventilation, then I'll move to the... So non-invasive ventilation, I tell you from our study in MERS, the patients who were treated with non-invasive ventilation had a failure rate of 92%. So almost all of them failed. So you need to keep in mind if... so that's why some ICUs actually don't use non-invasive ventilation at all in this setting, because of the infection control and because of the failure rate. But if you use it, I think it should be really time-limited trial and don't keep patient struggling for a long time. This is
actually we have a question. We have a question about the timing of non-invasive in the chat room. For how long you can keep your patient on non-invasive?
I don't think there is a magic time, but it depends on the patient response. It depends on how the patient look. It's the problem when people keep patients on non-invasive for a long time. And what we found in our study, the one who failed non-invasive ventilation actually become more hypoxic than those who were intubated from the beginning. They require more nitric oxide and oxygen rescue therapy. So
you mean after intubation?
After intubation. After intubation.
If I can jump on that, it's again a little bit the same problem. That with non-invasive ventilation or CPAP, you can treat oxygenation, but it does not necessarily mean that the patient will do better.
Yeah.
And the work of breathing may worsen, and you may therefore intubate the patient at a later stage because you kept the oxygenation better and you did not decide to intubate. So I agree that we decided not to use non-invasive ventilation for these patients.
Yeah. For the ARDS management, and I would love to hear Dr. Burchard, I think at this point of time, I think we follow the standard of ARDS, honestly. I think we have no other evidence to say that we need to follow different standards. So typically, we would follow the ARDS network protocol and see the patient respond and adjusted like any other severe ARDS patient.
So maybe I can show you what we are trying to do. So I can tell you what we are doing clinically and what we are trying to test in a trial.
Actually, we are waiting. We are waiting, Dr. Burchard, for this part.
Okay, and so I'm going to share this part. So this is the, I think one of the fundamental questions, and there had been a lot of discussion in the literature, is whether these patients are recruitable or not. And I think it's the same answer than for any ARDS. It depends. Some patients are very recruitable, some patients are not recruitable. And what we have been studied since many years is that this is not very well indicated by oxygenation. I think people need to keep in mind that, and again, going back to the studies in the 1980s, it was shown that when you decrease cardiac output with PEEP, independently of recruitment, you increase oxygenation because there is less part of the blood going into the shunt area. So you decrease the shunt independently of the recruitment. And you may remember that Peter Sutter in 1975 showed that you may increase PaO2, but your oxygen delivery will go down. So unfortunately, I don't think that oxygenation is a good marker of the recruitability. Of course, if the lung is very recruitable, respond well to PEEP, usually you see an increase in oxygenation. But even a lung which is not recruitable, you may see an increase in oxygenation with high PEEP. So what we do is a simple test, and we spent many years to validate this test, which we call the alveolar de-recruitment technique. And I'm going to show you a brief video describing how to do it in practice. So this is the schema. The patient is ventilated in volume control at a PEEP of 15. Then we reduce the rate on the ventilator, so we eliminate auto PEEP. And abruptly, in just one cycle, we go from a PEEP 15 to a PEEP of 5, which means we drop the PEEP by 10. And of course, the tidal volume, which is expired at the next breath, is much larger than the usual tidal volume, because you have the addition of the inspired volume plus the volume which is trapped by PEEP. And we calculate, very simply, we subtract the tidal volume and we calculate this volume trapped by PEEP, and we compare to the volume predicted by the compliance at low PEEP. So at low PEEP, you see, we measure the plateau pressure of the compliance, and we consider that the compliance measured in this condition is the compliance of the baby lung. And if the baby lung is not recruited, the increase in volume, or the volume trapped by PEEP, will be exactly predicted by this compliance at low PEEP. So we do a very simple ratio of the compliance at low PEEP to the volume recruited divided by the delta PEEP. We call that the recruitment to inflation ratio, and we use it to assess at the bedside if the patient is recruitable or not. In simple terms, it tells you when this ratio is high, that a large part of the pressure or volume will go into the recruitable lung. When this ratio is very low, it means that most of the increase in volume will go into the baby lung, and then the risk of distension. So I'm going just to show you a very brief video which we did. Sorry, I have to share my my screen with the good part. So this video is available for everybody interested. It's a web page called rtmaven.com, rtmaven.com, and we have put a number of calculators to help calculate, for instance, this ratio. And I'm going to show you this recruitability maneuver in real time to show that it's feasible on any ventilator. So I'm going to put it in the whole screen. So what we do here is, as you may recognize, we use volume control ventilation. We have a small pause, which allow to measure compliance. And the first thing we do is to reduce the respiratory rate, so to be sure we don't have any auto PEEP in the system. So of course it's a long expiration, you do it once or twice, and then you decrease the PEEP from 15 to 5. So you see the drop and you see here, if you look at the expired volume, you see the next volume expired is much higher than the usual tidal volume, because it's the sum of the predicted tidal volume and the trapped volume. So once it's done, you measure the plateau pressure at low PEEP and you go back to your initial settings. So this is done in less than 1 minute, and it's feasible on every ventilator. And this is one of the things we want to test in our trial. So maybe I'll finish by showing you what we would love to do in our trial. So if I go again to this is the schema of randomized control trial we want to start internationally. And we will have an experimental arm where we will adjust the PEEP based on this measurement of recruitability. If the patients are recruitable, we will increase the PEEP up to a plateau pressure of 28, an approach which was used in the EXPRESS study, and you may know that the EXPRESS study was the only one which showed some difference between the two arms. There was less days on the ventilator, for instance. If the patient is not recruitable, we will keep the PEEP between 8 and 12 based on the clinical tolerance, but we will not try to increase the PEEP. We expect that in the experimental arm, probably half of the patients will have low PEEP, half of the patients will have relatively high PEEP. And the next thing we'll do is that when we go to spontaneous breathing, like pressure support ventilation, we will control respiratory effort by using the occlusion pressure, the P01, which is now available on all ICU ventilators. And we have published recently a study showing that if you keep this value of P01 or occlusion pressure or P.1 between 1 and 4 centimeters of water, you're probably in a safe range of effort. If you're below that, you may risk disuse atrophy of the diaphragm, but if you're above that, you may risk self-inflicted lung injury. So this will be our experimental arm. And just to finish this story, just one word about the control arm. We changed it a lot because initially we said, okay, the control arm should be the low PEEP FiO2 table because this is what people are using during lung save, for instance. But then the guidelines recommended mostly the high PEEP. So we say, okay, let's use the high PEEP FiO2 table. But then there have been discussions all over the world. Maybe high PEEP is sometimes dangerous in this patient. So what we decided is that every center will decide which PEEP FiO2 table they want to use. If they are more comfortable with the high PEEP, they will use the high PEEP. If they're more comfortable with the low PEEP, they will use the low PEEP FiO2 table. And even it will be possible to decide individually for one given patient, I will use the high PEEP or I will use the low PEEP. And I think we decided this control arm to make the study acceptable by more centers, and also because it reflects the actual discussion about the uncertainty of using standardized PEEP. We think that an individualized approach like this one is, we hope, is better for the patient.
Very interesting, actually. Very interesting study. We hope you get your favorite outcome.
Thank you, and I invite all of you to participate as
Sure.
if you continue, unfortunately, to see COVID-19 patients.
A couple of questions about the study, because we are running a little bit out of time. The first, do you find that all the patients can go in the PEEP strategy from 15 to 5 and putting the patient on a PEEP of 15? Is it a little bit safe in the presence of vasopressors or cardiac dysfunction, or it is the routine?
Okay, so maybe an important point is to say, so as you have seen, the test we do is between 5 and 15, right? Yes. We use these levels because I think they are very, they are clinically used most of the time. We usually, clinicians use between 5 and 15, so it's not extraordinary level. But this is also a limitation because we just test the recruitability between these two levels. And for instance, we decided in the study not to enroll patients with BMI over 40, because we think these patients with BMI over 40, they may need higher PEEP levels. And therefore, the test should be done at a different level of PEEP, but that becomes a bit too complicated. So your question is it acceptable to do 15 to 5? I think yes. As you may know, the two PEEP FiO2 tables recommended now go up to 24, right?
Yes, yes, yes. Another question is if it is a single breath technique and your patient is having a variable recruitability along a couple of days, maybe he's not recruitable today. So you do it how many times? If the patient is not recruitable, can I do it after 6 to 12 hours maybe? Or?
Yeah, that's a very good question. And in fact, to make it simple, we're just asking to do it once a day, but there is no problem if, because this is so simple that really it can be repeated. And we use the technique in the patients in Wuhan with colleagues in China. And they found that the test, the recruitability was generally going up after a long session of prone positioning. So in the study, we just require to do it once a day, but it's always possible to do it more frequently. We just wanted to minimize the need to enter the room and to do manipulation on the ventilator.
Dr. Ahmed?
Thank you, Dr. Burshad. Actually, I think we need to have another webinar specific, especially for recruitability and ARDS management. Because of sake of time, just a small question for Dr. Burshad before I will go to Dr. Yassin about the innovative modalities for optimization of PEEP and tidal volume for patients like EIT or capnometry. There is a space for these modalities in COVID patients currently, or a sort of luxury?
So if I understand correctly, your question is about the new imaging modality like electrical impedance tomography,
yes,
right?
Yes.
I think it is a very, very interesting technique. Unfortunately, COVID arrives at a time where we don't know completely, we don't know enough how to use this technique. But what we started to see with the electrical impedance tomography is that the regional effect of the pressure we deliver may be very different from one patient to another. And for instance, we have seen that, we published that in the Blue Journal, that some patients, the typical ARDS patient, most of the ventilation go in the ventral part of the lung, right? Because you have the density in the back. Then you increase PEEP and you reopen some part of the dorsal part of the lung. But when you go to excessive PEEP, you see that most of the ventilation will now go into the dorsal part because you are hyperinflating the ventral part. So for instance, a very simple index like the ratio of the fraction of ventilation going into the ventral versus dorsal is for us a very good incentive to say, oh, this patient is receiving too much PEEP, we should go down. So I think it's a fascinating technique, and we'll use it more and more.
Thank you, Dr. Yassin. Time is passing, but I know that you have experts that have landmark trials for steroids in MERS-CoV. Briefly, there is a space for steroids in COVID patients?
So thank you. This is a very important question. I think this is an area of great discussion and debate. So you are referring to our study on MERS. It's an observational study on a cohort of patients with MERS. And what we found that when we adjusted for time varying confounders, that steroids did not impact mortality, but it prolonged viral shedding, viral RNA shedding, viral RNA by PCR. There are several observational studies and systematic reviews in influenza that demonstrated that possibly steroids are associated with increased risk of death. The problem with these studies that they are observational. Many of them did not adjust for the indication for steroids. So really it's hard to make sense whether this is really a good association or this is just simply confounding. On the other hand, the randomized controlled trials in ARDS showed either neutral effect or some of them showed benefit, especially the latest trial that showed benefit, and systematic reviews of all existing studies suggested perhaps a benefit. So to use steroids in COVID or not, we're not sure. And it is possible, as I said, that there are, I think there are patients who would benefit from steroids, and there may be patients who are hurt by steroids. And we, at present, we don't know which one are which. There are ongoing clinical trials on steroids in COVID-19 at present, multiple clinical trials, but our results are not out yet. But that's going to be a very interesting question. I think the more interesting question is what patients, what type of steroids, because people believe different steroids do different things, and what time of illness. Is it early, intermediate, or late in the phase of treatment?
Thank you, Dr. Mohammed.
I think we're getting out of time, but actually our chat room have two questions. I am excusing Dr. Ahmed and the panel to ask them rapidly in 1 minute. What about ECMO and what about pediatrics? Because Dr. Melvet and a lot of our pediatricians are joining us today, and they are asking about what about pediatrics, and the other group is asking what about the ECMO. Please.
So I'll maybe do the ECMO one. There are two aspects for the ECMO. I think one, if you are talking about ECMO during a disaster or outbreak, probably ECMO is not your friend, because this is really time resource intensive and could be taking a lot of resources towards one patient. However, if you have only very few patients in the ICU, I think then ECMO might be a good option. The reports that we are getting on ECMO are really mixed. So some of them saying good, some of them saying not that good. It's probably related to the selection criteria as well. So it might have a place. We have a patient now in our ICU, complete white lungs. I don't think he would have survived at all without ECMO. And now he's showing some improvement, so we'll wait and see. So in some patients, it might be beneficial. So I think in this setting where we don't have a lot of overwhelmed with cases, ECMO may be reasonable after you exhaust other options.
Okay, what about the, Dr. Laurent, about the pediatrics? What do you think? Dr. Laurent?
Well, I've no expertise in pediatric except that it seems extraordinary that kids seems to be protected. For instance, we are quite busy in Toronto with COVID-19, and we have meetings every week with different sites in different ICU in the city, and in the sick kid hospital, they didn't see any patient in the ICU. They saw some pediatric case in the hospital, but no one in the ICU. So interesting. The more we look like a kid, maybe the more we are protected. I don't know. So.
Thank you.
If you allow me, last question I'm facing actually. In patients who have a refractory acute hypoxemic respiratory failure, when we can define our goal or redirect our therapy or code the patients, we can consider COVID itself as alarming for no code.
For goals of care.
Yes.
So deciding about goals of care in patients with COVID.
Yes.
I think this really comes down to the triaging in case of you have large number of patients. Again, I think this depends on the context. If you are dealing with 1 or 2 patients, I would treat him same way as any other patient with severe pulmonary infection and use the same practice I would use normally. But I think you are referring if you have limited resource, number of ICU beds, and you are faced with a very large number of patients. And in this case, people have suggested a trial of treatment for several days. Now, how much is this? Could be 10, 14 days, but there is no rocket science about this, honestly. And you have to see how the patient behave and use your resources to the patients who are more likely to be benefits. In Saudi Arabia, we just finished an ethical guidelines for the kingdom about triaging and prioritization of patients. You are trying to use your resources to the best of the community. So try to benefit the most number of people. So there's no point of putting all your resources on one patient who has very limited chance of survival. If that answers your question.
Yes, thank you, Dr. Rashid. Before we close, Dr. Bouchard, what's your take-home message to us in a very...
Okay, maybe I will say 3 things. We have discussed a number of therapeutic options. I think we need to be very reasonable, and the best by far, when it's possible, when we think of a new drug, a new treatment, a new approach, is to try to join randomized control trials, because this is where we will have the solution. Just as an example, I had colleagues who were asking me, should I put these patients under full anticoagulation or give TPA? And I had 2 colleagues telling me about patients with cerebral hemorrhage. So I think we need trials, because the treatments we have. So be first message, be reasonable, and try to enroll patients into randomized trial if it's possible. Second message is that again, think that these patients are severe ICU patients, and do like you would do for the optimal care for usual ICU patients, like an ARDS patients, before starting something else. And the third thing is that there is indeed a specificity to this disease, which you need to take into account, which you can approach by a really individualization of the assessment of the patient of the therapy. As Yassine was suggesting, it depends very much on the context. If you have a major burden of a big surge, that may be difficult. But if you have time and good people to do that, the individual assessment of each patient is very important.
By the end of this session, I would like to thank my co-moderator, Dr. Ahmed. I'm very, very grateful for Dr. Laurent and Dr. Yassine for the great help and great effort in sharing us with this very valuable information. And we hope we can meet another time in better conditions very soon. Thank you.
Thank you.
Thank you
very much. Thank you very much. Bye-bye.
Stay safe, inshallah. Bye. Thank you.
Yeah, bye.